Welcome back to the Deep Dive. Today, we're tackling, well, one of the most intense and structured physiological events there is, labor and delivery.
It really is a critical process. It's incredibly time sensitive, involves so many body systems, and clinicians need, let's say, a very clear roadmap for assessment and what to do next.
Absolutely. So our mission today is to give you that clinical shortcut, that understanding of the intrapartum period.
Right.
That's the really powerful time from when labor starts right through to delivering the placenta and the immediate recovery afterwards. We're going to unpack the signs, the stages, all those high-stakes decisions.
And, to manage something this dynamic, medical professionals don't just wing it. They rely on a core framework, like the ultimate checklist, really, for checking progress and potential risks. It's the 4 Ps of labor.
The 4 Ps. Okay.
Yeah. If something isn't going right, they can usually pinpoint which P is the issue.
Okay, but before we even get to the Ps, we need to know, is this actually labor starting? Our sources talk about 8 signs that suggest labor is coming, the premonitory signs.
That's right. And they range from things you'd expect, like contractions getting noticeable, maybe some backache, the bloody show, to signs that might surprise you a bit, like gastrointestinal changes are pretty common, sometimes even a small weight loss right at the end.
I find the less obvious ones fascinating, like the energy burst.
Oh, yeah, the nesting instinct.
Right. You're about to run a marathon, basically, but suddenly feel like cleaning everything. That's actually a clinical sign.
It absolutely is. But the one sign that really shifts the clinical picture, from getting ready to risk is now imminent, is the rupture of membranes, ROM.
And there's a real urgency around ROM, isn't there? Why is that so critical?
It's the clinical tripwire, really. Once that amniotic sac breaks, labor usually kicks in within about 24 hours. But the major concern is safety.
Infection.
Exactly. A prolonged rupture, meaning it's been longer than 24 hours, significantly bumps up the risk of infection, specifically chorioamnionitis.
Yeah.
So that immediately triggers much closer monitoring. It changes the whole risk profile.
So let's say someone's feeling contractions, but the water hasn't broken. How does a clinician tell the difference between true labor and just, a false alarm?
Okay, this is the key takeaway. It really boils down to one single factor. True labor is only confirmed by cervical dilation.
Change in the cervix.
Yes. If the cervix isn't demonstrably changing, dilating, thinning out, then it's still considered false labor no matter how strong those contractions might feel.
So what about the contractions themselves, the UCs? What should we know about telling them apart?
Right. True UCs, they find a pattern, they become regular, they get progressively stronger, and crucially, their intensity increases if you walk around or change position.
Okay.
Comfort measures don't really stop them. False labor contractions, on the other hand, are usually irregular, often just felt low in the abdomen, and they might actually go away if you rest or move.
Okay, so we've established it's true labor, the cervix is changing. Now we bring in that diagnostic tool you mentioned, the 4 Ps. This is how clinicians manage the whole thing.
Exactly. This framework helps them figure out where problems might pop up, which is vital because, labor needs all 4 elements working together smoothly.
Makes sense. Let's break them down. P1, powers. This sounds like sheer force.
It is. It's the engine. P1 is about the involuntary uterine contractions, the UCs, and also the voluntary pushing effort later on.
Okay.
The key question for the team is always, are these contractions effective? Are they actually doing the job?
Meaning strong enough, frequent enough?
Strong enough, frequent enough, long enough to actually change the cervix and help the baby move down.
Yeah.
If the powers are weak, things can stall out.
Okay, so if the engine's running, we need a clear road. That's P2. Passage. What's included in the passage?
The passage is, it's twofold. You've got the hard part, the bony pelvis. It needs to be the right size and shape.
Right.
But there's also the soft part, the cervix, the vagina, the pelvic floor muscles. They all need to be prepared and yield appropriately. If the pelvis is too narrow or the cervix just won't open, well, the pathway's blocked.
Which leads us logically to P3, passenger. That's the baby. And it's not just about getting through, but how?
Correct. The fetus, the passenger, needs to be a reasonable size and in a good position. Ideally, head first, chin tucked down, what we call flexion.
Makes sense.
And this is where a really critical safety point comes in. The condition called cephalopelvic disproportion, or CPD.
Right, CPD. That means the baby's head is just too big for the mother's pelvis, or the pelvis is too small. A mismatch.
Exactly. And if CPD is suspected or confirmed, the medical decision is swift and clear. assisted delivery tools, like a vacuum or forceps, they are not used.
Off the table completely.
Completely off the table. The risk of injury to the baby or mother is just too high when you know there's a size mismatch. The plan immediately shifts towards a cesarean section. Knowing that is high stakes.
Wow, okay. Finally, P4. Psyche. This one feels a bit different compared to bones and muscles. How does the patient's mental state really affect labor?
Oh, it's incredibly important. The patient's emotional state, their anxiety levels, past experiences, the support they have, even cultural factors, it all plays a role.
How so?
High stress, fear, or anxiety can actually trigger stress hormones. And those hormones can sometimes inhibit the uterine contractions, the powers. They can slow down or even stop cervical dilation.
So managing the psyche is actually part of managing the physical progress.
Absolutely. Supporting the patient psychologically is just as vital a task as monitoring the contractions or the baby's heart rate.
All right, so the 4Ps are assessed. Things are hopefully moving along. Now we look at the timeline, the 4 stages of labor. Can you walk us through that map?
Sure. The first stage takes the longest, and it's actually broken into 2 phases itself. The latent phase is the early part.
Slow and steady.
Very much so. It goes from the start of regular contractions up to about 6 centimeters dilation. Contractions are usually milder, and the focus is really on support, comfort, staying hydrated.
Then, at 6 centimeters, things pick up speed.
Right, you shift into the active phase. This is where dilation happens much faster, going from 6 centimeters all the way to full dilation, which is 10 centimeters.
Okay.
Contractions get stronger, closer together. This phase demands continuous, really vigilant monitoring. The patient's usually pretty focused on coping by this point.
Makes sense. Then the second stage, that's one everyone thinks of, right? Pushing.
That's it. Full dilation until the baby is born. The active pushing phase.
Followed by the third stage. Seems short, but you said it's critical.
Relatively short, yes, but absolutely critical. This is from the baby's birth until the placenta is delivered, usually within about 30 minutes. The main thing we're watching for here is excessive bleeding, hemorrhage.
Okay. And the fourth stage. What happens then?
That's the immediate postpartum recovery, usually the first hour or 2 after delivery. We're closely checking uterine tone, making sure the uterus clamps down firmly to control bleeding, and also encouraging that initial skin-to-skin contact and bonding.
Now, sometimes those powers need a boost, or maybe things need to get started. Let's talk pharmacology, the interventions. If the cervix isn't ready, what's used to ripen it?
Good question. We often use prostaglandins, like dinoprostone, which you might know as Cervidil. It chemically helps soften and thin out the cervix. Think of it like prepping the door before trying to open it.
Okay, prepping the door. And if the door's ready, but the powers are weak or haven't started, how do you strengthen or induce contractions?
Then we turn to uterotonics. Drugs like misoprostol or Cytotec, and especially Pitocin, or synthetic oxytocin.
Pitocin is common, right?
Very. And a key advantage of Pitocin is that it's titratable.
Meaning you can adjust the dose very precisely.
Exactly. You can carefully increase or decrease the infusion rate. That gives the clinician really fine control over how strong and frequent the contractions are, which helps minimize the risk of overstimulating the uterus.
That makes sense. Control is key. What about the opposite scenario? Say a baby might be coming preterm and you need to help its lungs mature quickly.
Yeah, that's a different kind of race against time. If preterm labor looks likely, we give the steroid betamethasone, often called celestone. It helps speed up fetal lung development. It's usually 2 intramuscular injections given 24 hours apart.
And if you need to stop contractions altogether, say in preterm labor?
Then we use a tocolytic drug, like terbutaline. Its job is basically to relax the uterus and halt contractions.
With all this going on, monitoring must be constant. What are some non-negotiable protocols during labor?
Patient positioning is a big one. They really need to be repositioned fairly often, usually about every 2 hours. And one absolutely crucial detail: making sure the position doesn't compress the superior vena cava.
A large vein returning blood to the heart.
Yes. Lying flat on the back can compress it, reducing blood return to the mother's heart, which can then compromise blood flow and oxygen to the baby. So avoiding that is key.
And what about checking progress? The sterile vaginal exams, SVEs?
Yes, the SVEs. They're necessary, but we do them sparingly. Only when we really need to know the dilation, effacement, that's the thinning, and station, how far down the baby is. We want to minimize them to reduce infection risk.
Speaking of infection, you mentioned ROM earlier. What's the protocol if the membranes have ruptured?
Critical monitoring point. If the water is broken, the patient's temperature needs to be checked very frequently, typically every 1 to 2 hours. Even a slight rise could be the first sign of chorioamnionitis.
Okay, let's shift to comfort. Managing that psyche P. What non-drug options do the sources highlight?
Oh, there's quite a toolbox. Things like patterned breathing, relaxation techniques, counter pressure on the lower back, sacral pressure massage, light stroking called
Hmm.
effleurage, using heat or cold packs, aromatherapy, sometimes even hypnosis.
Hmm.
And simple tools like a peanut ball between the legs or using a squatting bar can really help with positioning and opening the pelvis.
Lots of options. Yeah. Now, if someone opts for pharmacological pain relief, like IM or IV narcotics, what's the main clinical watch out there?
The biggest thing is that they cross the placenta.
Right, they get to the baby.
They do. This can cause some sedation in the baby, maybe decreased heart rate variability on the monitor, or some respiratory depression right after birth, what we might call a sleepy baby.
So there's a timing consideration?
Generally, yes, clinicians try to avoid giving these narcotics once labor is really advanced, maybe after about 7 centimeters dilation, to reduce those potential effects on the newborn.
And the epidural. The spinal or epidural block.
Mhm.
Huge relief for many, but what's the primary risk everyone's watching for?
Number one concern, hands down, is maternal hypotension, a sudden drop in the mother's blood pressure.
Why is that so dangerous?
Because that drop can significantly reduce blood flow and therefore oxygen getting to the baby through the placenta. It can cause fetal distress.
Oh,
And that is precisely why the monitoring protocol after an epidural is so strict. We usually give a fluid bolus beforehand to help prevent it, and then blood pressure checks are super frequent, like every 2 minutes initially, then every 5, then every 15, until we're absolutely sure she's stable.
that intensity makes sense now. It's all about fetal safety. Clearly, a lot goes into keeping labor progressing safely. But sometimes the 4Ps just don't line up, and interventions like induction are needed. How do doctors gauge if an induction is likely to work?
They often use the Bishop score. It's a system to assess how favorable or ready the cervix is.
How does it work?
It looks at 5 things: dilation, effacement, the cervix's consistency and position, and how low the baby's head is the station. You get points for each. A score of 8 or more usually means the cervix is considered favorable.
And a favorable score means a higher chance of successful induction.
Generally, yes. It suggests the body is more prepared, increasing the odds that the induction will lead to a vaginal delivery rather than ending in a C-section for failed induction.
And speaking of cesarean sections, or CS, what are the main reasons one might become necessary?
Well, the most common reason is failure to progress, which is also called dystocia. Basically, labor stalls out, there's an issue with one of the 4Ps, often powers or passage.
Okay.
Other big reasons include having had a previous C-section, although we should definitely mention that TLAC, trial of labor after cesarean, and potentially having a VBAC, vaginal birth after cesarean, are options for many now.
Right. Not automatic repeats anymore.
Not necessarily. Then there are emergency situations like fetal distress, significant problems with the placenta, or certain maternal health conditions that make vaginal birth too risky.
Got it. And just a quick practical point, what about eating or drinking during all this?
It really depends on the situation and the risk level.
Hmm.
Often, clear liquids or ice chips are allowed, maybe hourly, just for comfort.
Huh.
But if a C-section seems likely or becomes necessary, the patient usually needs to be NPO nothing by mouth. That's to reduce the risk of aspiration if anesthesia is needed.
And after a C-section?
Recovery is different. A regular diet usually isn't started until hours later, once we can confirm that bowel sounds have returned, indicating the digestive system is waking back up after surgery.
Wow. We've really mapped out the entire clinical journey, from those first subtle hints of labor through delivery and all the potential interventions. It's so clear how that 4Ps framework brings structure to what could seem like a chaotic event.
It really does. Almost every decision, every medication we talked about, every monitoring check fundamentally, they're all aimed at optimizing one or more of those P factors,
Trying to ensure the passage and passenger work with the powers.
while keeping the psyche as stable and supported as possible. It's all interconnected.
And that brings us perfectly to our final provocative thought for you today. The sources stress that dystocia difficult labor happens when one or more of the 4Ps isn't working right. So, given that success depends on this delicate synergy physical powers, a suitable passage, the passenger's position, all balanced by the mother's psyche, think about how much of the medical management we discussed is really about anticipating potential failures.
Right, like checking temperature constantly after ROM or carefully titrating Pitocin.
Exactly. It's all aimed at spotting trouble early and stabilizing those Ps before things escalate to the point where an emergency cesarean is the only option left. It shows labor isn't just biology, it's this intricate dance between human factors and medical readiness.
Anticipation and readiness, that's absolutely key to safe delivery.
Well, that's all the time we have for this deep dive. We hope you feel better equipped with this clinical roadmap for labor and delivery. We'll catch you next time.